Well, I'm a surgeon, so much of what I do is I spend my time thinking about, the biology of the tumor and can surgery intervene in the biology for a therapeutic benefit. And so in the past, when we didn't have a lot of systemic therapies, surgery usually was the answer. So it may be uncommon for a surgeon to talk about a diminishing role in the management of kidney cancer. But in fact, to a certain extent, there's a growing role in the patients with metastatic disease. We call that consolidative therapy, right? So a lot of new data regarding should surgery be up front for patients with metastatic disease? That's the Carmina trial and the Surtime trial. And I think there's recognition now that patients are not misserved by giving them upfront systemic therapy. So they get upfront systemic therapy, but then what happens is these patients become good responders and prolonged durable CRs in some cases, or PRs more likely. And then the question then becomes is, do you go back to the surgical option? So how do you consolidate the results of the systemic therapies with surgery? So I think we're going to start to see a lot more of that. The idea, of course, is, we're talking now about lifelong therapies for people that, are not cured. If we could get them to a point where they've got a significant PR from dual therapy or from combinations, and then we could take them to the operating room and excise them, can we now give them a period of time where they're off therapy for long periods of time? So yes, we could talk about the mechanistic aspects of the new therapies that are coming down, the HIF inhibitors and other types of combinations and sequential therapies, but don't forget that surgery really is evolving, and the role of surgery in patients with metastatic disease may look a lot different 3 to 6 or 5 years from now.